So how do we prevent retinal detachment? Essentially, if we prevent a posterior vitreous detachment from happening, then we can prevent retinal detachment. So it is not possible as of now to prevent vitreous liquefaction and posterior vitreous detachment. On the other hand, we can induce a posterior vitreous detachment, reduce the traction, that can also decrease the risk of retinal detachment. But it's possible right now with invasive surgery, but with ocriplasmin, you can create a posterior vitreous detachment in many patients, but it's very limited because you have an increased risk of creating retinal breaks as such. So right now what we do is to create a chorioretinal adhesion around retinal breaks or precursors of retinal breaks. So that is how we are able to prevent a retinal detachment in the present scenario. We will first see how we do it, then we'll go on to see why we do it and where we do it. So the usual methods of treatment are laser photocoagulation and cryotherapy, and laser can be delivered in 3 different ways: the slit lamp, the laser indirect ophthalmoscope, and using the diopexy probe. Cryotherapy, it's applied as single burns touching each other around the lesion, and wherever possible we extend it to the ora serrata. We should not treat beneath a bare RPE, that is beneath an open break, because that can release the retinal pigment epithelium and that can increase the risk of a PVR formation. Coming on to laser photocoagulation, how do we treat a laser, a lattice with laser? 2 to 3 rows of laser are usually used to surround the lattice, and as wherever possible extend it onto the ora serrata. So what we need to understand when we do laser photocoagulation or cryo is that in any retinal break or half-shoot tear, the traction persists in the anterior flap out here. The anterior flap still has the persistent traction because the vitreous is still attached to it, so it keeps it open. So wherever possible, we have to extend these laser burns onto the ora serrata. That is the reason why I keep insisting on extending it onto the ora serrata. Whenever there is a break with associated subretinal fluid, I prefer to use laser photocoagulation in contrast to cryotherapy, because cryotherapy does induce some amount of inflammation and exudation, and so what is recommended as retinal detachment after cryo, instead of preventing a progression of the detachment, can result in progression of the detachment. So wherever possible, better to use laser photocoagulation. Diopexy is a way of delivering transcleral laser energy. We can use the diopexy probe much like the cryotherapy probe and surround the retinal break, and it can be used to treat breaks through a scleral buckle itself, because scleral buckle is transparent and the laser energy can go through that. The only thing is, in cryotherapy we can use it when there is a subretinal fluid, but diopexy doesn't work like that. Diopexy can work in areas where the retinal pigment epithelium is in opposition to the retina. Now let's come to the important question: what do we treat? Symptomatic breaks, the breaks where the patients present with flashes and floaters, have to be treated because symptoms indicate there is an unrelieved traction. So this unrelieved traction is the reason for the symptoms. What does this traction do? It keeps the flap open, much like a doorman keeps the door open for you, allowing the fluid vitreous to go through the break and contributes to the subretinal fluid and progression of the detachment. So if the risk of retinal detachment in a symptomatic break is as high as 25 to 90%, and if we treat and close the break, the risk falls down to less than 5%. So first we treat symptomatic tears, which is essentially a horseshoe tear. Then we also should treat lesions which predispose to formation of horseshoe tears, which is in primary lattice degeneration. So lattice degeneration is a common problem. 6 to 8% of all people do have it, but clinical retinal detachment develops in less than 1% of the patients. But in contrast, you see patients with retinal detachment, 30% of these patients will have a lattice inside. So we need not treat all lattices. What are the lattices we treat? Whenever a patient has retinal detachment in one eye, lattice degeneration in the other eye, we treat. And if there is family history of retinal detachment, or if the lattice is associated with flashes and floaters, we treat. Because family history of retinal detachment indicates that the hereditary factors predisposing may be there in this patient as well. And there is more than 5% risk of these patients developing retinal detachment. High myopia is also an indication where we have to be careful and do prophylactic treatment. So higher the myope, more are the risks. So as you can see, 8 diopter, if the patient has a ring like this, if that band of detachment, that band of retina can detach and can develop anteriohyoid proliferation and give rise to problems also. So better to connect them to the ora here and there. Another technique has been described in the literature where they have completely lasered a band of the vitreous base, and they call this as an aura secunda. They're creating a second aura, and they have found the risk of retinal detachment comes down dramatically with this technique. Another area where we may have to do prophylactic treatment is a patient with a retinoschisis. Once again, a juvenile retinoschisis is bilateral, so one eye may have retinal detachment, and we need not treat all retinoschisis patients. We look carefully to see if they have an outer layer break. So the outer layer break is the one which predisposes these patients to a retinal detachment. So we treat outer layer breaks. Inner layer breaks are too huge, we can't treat them, only the outer layer breaks. Acute retinal necrosis, this is a patient with acute retinal necrosis and the retinal detachment in one eye. The other eye has peripheral areas of retinal necrosis. So we have to be particularly aggressive. The moment the vitreous clears enough for us to treat, we have to be particularly aggressive and treat them with quite liberally with the laser, treating the healthy retina, not into the necrotic retina. The border between the healthy and necrotic retina, the healthy retina has to be treated quite well. Lesions that may not need treatment, an atrophic hole does not need treatment unless the vitreous is attached to the atrophic hole. Asymptomatic lesions and tears, in fact the literature suggests even asymptomatic tears you need not treat them because the benefits have not been proven as yet. So when do you treat an asymptomatic lesion? We usually treat an asymptomatic lesion if the other eye has a retinal detachment or the patient is one eye, just to be on the safe side. Subclinical retinal detachments and the retinal detachment which are asymptomatic, we treat them prophylactically. So in summary, symptomatic HST, lattices, dialysis, we treat them all the time. Operculated holes sometimes, atrophic holes rarely. And the basic problem is the PVD. PVD is the critical event, and any patient presenting with symptoms of PVD, 15% of them have retinal breaks. So you have to look at them very, very carefully. Many times it may not be possible to look at them carefully because they may have an avulsed vessel and a vitreous hemorrhage, precluding fundus examination. So we advise them bed rest for a day or two and then re-examine them to see if we are able to find the breaks and treat them at the earliest possible. In this situation, when there's a bleeding inside and a horseshoe tear, I have found cryotherapy to be not a great idea. Despite the cryo, they proceed to detachment and they continue to have PVR as well. So I prefer to use laser in this situation. And I'm very much liberal with the vitrectomy. In about a week's time, the vitreous hemorrhage doesn't clear and I'm strongly suspecting a break, go ahead with the vitrectomy. Because once this patient develops a detachment, the risk of PVR is very high. So if we find the patient has come to us with symptoms but no breaks, what do we tell them? We tell them to come back immediately if the symptoms worsen. The flashes increase, the field of vision is lost, come back immediately. Otherwise, we see them within the first week and then 3 to 6 weeks later until the PVD detaches completely. Thank you very much for your kind attention.